medical school. Half of what we are going to teach you is wrong, and half of it is right. The problem we have is we don't know which one is which. And today we are confronting many cases that we don't know why it's working, and we go more by intuition than by reason. So let me show you this case. This case of mine. I touched it in 2002, and she had implants done by a friend of mine in 1999. She was 15 years old, and she finished the treatment in 1993. You can see extrusion, you can see the problem of bulk necrosis, the implant, and the crown on the lateral incisor. What I did the crown lengthening, internal bleaching. I placed my first zirconia abutment on top of Răng Hàm Mặt implant, and I did use two procedural crowns. High line, we did some crown lengthening on the side. And when I finished her, she was 25 years old, and this was in 2002. She had a Sarah 1, titanium abutment with an alumina crown. And 1 year and a half later, she calls me and she says, Iñaki, I have a problem, my implant has a problem, and I don't know what's going on, but I have a huge inflammation. Can you see me? Of course, I saw her, and what you can see here is cement here, cement here, cement here, cement here. At that time, in 2002, I didn't have any protocol for cementation of my crowns. Okay? At that time, we didn't have screws like only grip to compensate our angulations. So basically, she's now 38 years old. This is my crowns. I cleaned the sides, and this is how she looks like 13 years later. This is my work. Okay. So she came and she said, Iñaki, I'm not handle it anymore. I don't like my aesthetics. My teeth are growing, and they still are longer again. Can you do something? Yeah, I'm trying now. We have to cut the crown. You have a big problem because you have lost also papilla, local recession. So we need to do some grafts, at least one or maybe two grafts from the implants to bring back the scalp. So I cut the crown 13 years later, and then I was ready with my camera to see what was happening. I placed a provisional restoration with some pink. It's beautiful, and we didn't learn at all. We didn't start yet. To tell you the truth, I think this piece of cement was stuck on some tissue and collapsed when I took it off, but you can see all the amount of bacteria. We have an external hex in something that we were supposed to have a perfect fit. So it's impressive to see this. And what I did is I did 1 round of connective tissue graft. And we'll discuss tomorrow morning that the more you keep the abutment in place, the more you are limited on the amount of tissue graft you can graft crestally around the implant. So this is 4 months later. Usually when I use only connective tissue graft, I re-intervene after 4 months. At 2.5 I check and I see, well, papilla high, the papilla is level, the connective tissue of the buccal is not level. So I do the second connective tissue graft and I graft interproximally and buccally. The idea in prosthetics, the idea in periosurgery, that you always want to have the scallop of your pontic or your implant being coronal to the one you want to copy. In this way, you will always push the tissue and have a perfect scalloping of your crown. Okay? So you can see after the second round, you can see here that the papilla is a bit higher than this one, but pretty much everything is under the situation where I can improve the final results. Okay? Very much where I want it. I want to check if this papilla, if this tooth has a contact point. Every time I place an implant, I always take floss and check all the proximal contact among the rest of the teeth. If you have a diastema here, the tooth will move this time. So I always check the proximal contact between the teeth to avoid the migration of the teeth. So we are under an ideal situation to push the tissue and create something that looks nice. Now I have the chance to bleach internally the tooth because it became dark, and I place the provisional restoration. And I don't know how you control the contact points between your teeth and the implants. If you use an articulating paper, you have a problem, because you will always leave the thickness of the articulating paper you have used. We always control the contact points between an implant or between implants or between an implant and a tooth with filter. So we paint, we dry, we paint. You know that there is a certain steps. First, we control the contact point, and once you have a good contact point, then we check for the adaptation of the crown. So, interproximal contact points are really important for to check. Usually, if you look at my book, 90% of my teeth adjacent to the implant has a component. Why? Because I want the contact point that is as wide as possible vertically and horizontally. It goes from the tip of the papilla to the gingival embrasure and buccolingually as wide as possible. So you can see that I paint, I place it back. If it touches, you will see the white spot with the really thin grid, red band grid of diamond. I will cut this whitish spot until I'm done and I see all black. That means that I still have a contact and I will have a floss and a good contact point. Okay. If you use articulating paper, you will always end up with the space of the articulating paper. So we always control the contacts with black filter. Especially when you screw in a crown, the pressure you create, you can, if you have too strong of a contact, you can move all the teeth laterally. The patient is going to tell me, it's hurting all the way back to the first molar. Okay? So So you need to be careful, you need to be patient, and you need to control the contact points between your implant and the rest of the teeth. So every time you use final zirconia abutment as a provisional, always remove it and check if there is no cement excess around. And now I always use two totally independent cords. The cord that we use, the diameter is based on the mobility of the flap, how thick is the tissue. The cord should be just in front of your finishing line of the thread. The cord is there just to avoid the cement to flow apically. You need to teach your assistant how much cement you have to put inside the crown. The cement inside the crown is placed with a brush and is painted. All the surface of the internal crown is painted. We never fill the crown all the way up with cement. It's way too much. Okay. And then why two cords? It's always packed into the adjacent tooth. So once I place the crown, I can remove totally independently the buccal versus the palatal cord. I remove the buccal, but the palatal stays in there, so I can blow with air to see if there is no cement left on the socket. Here's what it looks like. I always go sideways on the adjacent tooth, so I can remove the cord in an easy way. So if you stay within the implant, it's impossible to go and capture it. Okay? She's coming back 1 week after, this is where we started. She came with her daughter, next patient. And this is what it looks like 1 year afterwards. You can see the teeth are splitted to avoid vibration as much as possible. But which is the reality in 2020? Well, she came because she fractured a little bit inside the edge. But you can see that even though we split it, the tooth migrated a little bit. Okay. So I would like to ask you, how do you solve an adjacent tooth continuous eruption? Do you have that in Vietnam? Of course! When was the last time you had to fix an interproximal contact next to an implant? Do you have that problem? Yes, I do. How do you manage a tooth restoration between two implants? Okay. I would like to discuss few cases. This is another one. This is how she started, a bridge, an implant that was buried, an implant, natural tooth, two implants. We placed 3-unit bridge, 3 years down the road, single crown, extrusion. The bridge is how we started. This is what we did. We brought 8 millimeters down the papilla, only with soft tissue. This is 7 years. Class 2. So which are the basic criteria for predictable success? Which are the expectations, the limitations? Do you always need a connective tissue graft? But for me, I always do a connective tissue graft. It is what saves my problems in an easy way. Why we need connective tissue graft? Well, until we don't make a prosthetic abutment where the fibers will connect to the prosthetics in a perpendicular way, we are in a certain way condemned to do connective tissue graft. Maybe in 100 years they will say, this Gamborena guy was crazy. He was doing connective tissue graft around implant. But today we don't have too many ways to solve this problem. So here is the problem. You can see, thanks God, she has a lot of soft tissue. So we need to bring 9 millimeters this tissue down here. Is it possible? Well, it depends your dexterity. It depends your knowledge, and it depends, of course, if the patient has sufficient soft tissue to really graft crystals. On her, she has 9 millimeters of tuberosity in this side, 9 millimeters of tuberosity in this side. So now it's a matter of being able to place 9 millimeters crystal, which is not easy. Okay? So if you look at the bridge, this is the situation. You can see we have a frenum, everything is recovered. You can see the vertical releasing incision just here, the implant that is buried. And for me, frenum is not my enemy, it's my ally. I almost never do upper frenectomy. You see why. So you can see here the red is the angulation of the implant, the blue is the angulation of the prosthesis, which is on the limit. And I will discuss that in more in depth, which one can be performed, which one we have to extract the implant. So this is the scenario. This is the first connective tissue graft, the first round of tuberosity connective tissue graft. This is how much I was able to improve the locally. The frenum was not removed. This is 4 months after the first surgery. This is the second surgery. This is 2 weeks after the second surgery. We place an immediate implant placement on canine to do a bridge with a pumping and a single crown central incisor. You can see this abutment is the same that the patient is wearing. We remove every single and make it as narrow as possible. This was a paragon implant. I don't have a healing abutment, but usually what I do is I remove as much horizontal component as possible of my abutment. I just leave the hex just to really be able to graft as much as possible where I need the best, which is breast. This is all soft tissue. So I have to go above the mucogingival line. I have to be above the fornix. The fornix is where the local soft tissue becomes the lip. So I have to go at least 3 millimeters into the lip to bring that soft tissue down. And now you have to recognize the difficulty. Which is more difficult? Shallow vestibule or high vestibule? The high vestibule. Why? Because with the high vestibule I have to go really high to really bring everything down. Okay? The shallower the vestibule, the easier it is to bring the tissue down. The higher the vestibule, the more possibilities to perforate the flap. Okay? The more the teeth are protruded, the more it's difficult to do the tunnel. So there are the position of the maxilla, the length of the maxilla, the premaxilla, is going to limit how much you will be able to advance your flap. Okay? Those are limitations inherent of the patient you are treating. So here we want to, the thinner the tissue, the more I do full thickness flap. Because I want to elevate the thickest flap possible so it doesn't tear me. And then I don't use the spatulas for cutting. I only use spatulas to stretch, to elevate, to create pressure on a tissue that has been already gutted and able to mobilize in a better way, or to control that my tunnel is perfectly tunneled, that I don't have any pieces of or remnants of tissue that doesn't allow me to glide my soft tissue. So you can see here that my flap, my tunnel is going to allocate my soft tissue, but I want to perfectly, I forget about the implant, I take out, you will see on videos tomorrow morning, how we deal with recession around implant. At that time, I didn't have videos, and I totally forget that it's an implant, it's like a ridge. And what I do is I first come from the outside in. See, outside in, I go into my flap. I'm going to insert my connective tissue through the medial aspect of my pigment into the tunnel. And then it's going to be sutured by 4 extremes in order to place it exactly where I want it vertically. Okay? And then I will make a hole, you will see it in videos. I will make a hole and I place my abutment in order to deliver my provisional that is not creating pressure on top of that tissue. Okay? So this is the second round of connective tissue. This is the result 15 days later. I place an implant. I want to bring more tissue distal. And this is how it looks like 15 days later after my second round of connective tissue graft. I place an immediate implant placement and plug it out vertically. Okay? And then I place the new provisional to push the tissue. I use TNMA provisional restoration. Usually those provisionals are too beautiful, so the patient sometimes delays a little bit the final result, which is a bit and a problem. But you can see that papilla has been raised 9 millimeters vertically. So this is where we started. In none of the situation we have grafted, so the tissue on top of it keratinized, and we kept, of course, the implant just to bring the tissue to a different height. We look at number 13. You see we left the cover screw and the angulation. I use gold abutment to compensate the angulation and able to restore this is where we started. This is how I finished. So basically what we're going to see is how to reconstruct the volume in compensate the volume loss only with connective tissue. I'm not going to talk about bone, but really, sorry. This is a video recall of the patient. She's coming from south of Spain. It's about 8 hours drive to Sydney. It's difficult always to find people to come back and do a checkup. It's about 3 years down the road and the situation. Okay. This is 7 years later. You can see how the tooth is growing because it has never been splinted, even though this tooth has a contact, this can become a problem. So far, she is not concerned, but one day she will come back. I would like to talk about connective tissue grafts, the donor side, the surgical techniques, the harvesting management, the benefits, the complication, and the management. Okay? The first question is, does pseudoepithelial connective tissue graft matter? Absolutely it does. For me, there are the first paper from the Ritchie group, which were showing what I was seeing clinically, which is that in tuberosity the tissue may tend to grow, and it's something that you should be aware of. If you graft from 3 to 5 millimeters in thickness, that tissue can grow in excess in some people. One of the tips I can give you is that if you find a patient that has lingual chlorides of bone, and you're gonna grab tissue from this person, you probably have hypertrophic reaction of the soft tissue. So that tissue tends to grow more than normal. Okay? This is related to bruxers and the thicker phenotypes. Okay? So this is the tip that we use. Okay? For me, there are 3 areas. If I use teeth, I use usually Zucchelli technique. I take the hard palate, okay? And I take what is called the lamina propria, which is the thicker and denser soft tissue, just below the epithelium. I only take the 1.2, 1.5 millimeter thickness of soft tissue. Okay? This tissue is the densest connective tissue you are looking for. Okay? Compare the tuberosity, same stains, or the retromolar pad. The retromolar pad is where the dentures should be lying onto. Okay? Sometimes you have enough for 2 premolars, if you have an extension, or one lateral, or even a central incisor. The tuberosity usually is used for, I use it for implants or defects. When I want the tissue to grow, in pontics, many areas that we can use this tissue. What is the difference between them? Is the collagen type. This collagen is type 1, and it has a continuous growth. It doesn't have vessels. You can see here the vessels. It doesn't have adipose tissue. So this problem, this tissue is a tissue that cannot be exposed to the oral cavity, because if it's exposed, it necroses. And I will show you what I mean by that. Okay? So I have 3 areas: tuberosity, retromolar pad, superficial hard palate. The best superficial hard palate is not in front of the first molar, is behind the first molar. This is the most glandular soft tissue you can find. This tissue looks like it's nothing, but usually it's trapezoidal. It goes from the lingual oblique line to the buccal oblique line. You have little amount of gingiva. It depends if the patient had wisdom teeth extracted or not. You can find a lot of tissue here. So I always touch it and have an idea how much and how little. Okay? So we are all the time exploring different areas. I know so many periodontists that always use this part for everything. No? We use a specific tissue for a specific problem. We are not like a restaurant, a menu for everybody. No, we are a restaurant a la carte. Okay? You have this problem, I'll give you this tissue. So let me show you where I use tuberosity between teeth. I use it when I have interproximal defect. Let me show you where I use, for instance, retromolar among teeth also. Why not? And let me show you where I like to use Zucchelli technique, thin tissue around natural teeth. Okay? So I will share with you different situations with different soft tissues. Okay? So the first one is this guy. It's a class 4 Miller or 3, I don't remember now. There is no palatal soft tissue. The challenge, it's a cardiac surgeon. He's coming from France to see me, and I told him, well, it's gonna take me a lot of effort to really be able to fill this gap, and this is how we finish. This is Patrick Rutten, one of my technicians I used to work with, and this is a group of Japanese people. And I choose him as a patient. I place an implant on the lateral incisor, and he told me, why not? So the Japanese dentist came to see how I did connective tissue and immediate implant placement on the lateral incisor. And he told me, why don't you change both central incisors? And I said, well, no. Those central incisors were done by Eric Van Duren, a really good dentist, and I say, the crowns are perfectly fitted. Let's do just a connective tissue graft from the retromolar part, because you have enough tissue for me to graft it. And this is the final result. And usually when I have a really dark tooth, if you add connective tissue on the buccal aspect, you will create a dissimilarity on the emergence profile. So what we do is I cut the root in order to have the same emergence profile with my soft tissue compared to the contralateral tissue. And this is how we do it. We reduce the diameter of the root of the patient. We do a class 5, of course, without touching the bone, and then we take a connective tissue from the palate, we thin it out just 1 millimeter, so it doesn't overcome and make it too bulky, to donut effect, and this is the final result. Okay? So let's look at how we take the connective tissue from the tuberosity. Usually this is the green part. We do a simple wedge technique, nothing new. But we take all of it. Why we do a wedge? This wedge is about 1.5 millimeter incision, and we deepicalize sideways about 1.5 millimeter in thickness. The thinner the tissue, the more in necrosis, the more pain for the patient. We want to have the incision at least 3 millimeters apart. So once we take all the volume inside, we just suture in one line. The bigger quantity of soft tissue in the tuberosity is on the crest and on the palatal aspect, not on the buccal. Okay. So what we do is we make incisions, remove all the soft tissue, and I will show you in a minute a video about how we do it. The idea is to calculate which are the distance of both incisions to end up with a line on a totally different level and cover the bone so it's not denuded, okay? So it's not painful for the patient. So this is the video. So we do it on a model of a dinosaur as a patient will be able to have a nice video. This wedge gets together at the end on the umbilical notch, which is the part here in the back, which is mucosa. And then you elevate 1.5 millimeter thick tissue following the anatomy of the palate. Usually this is about 1 millimeter thick, so you take your instruments as a guidance. You have the posterior nerve here. Usually we never bypass the length of your 15 blade, which is about 9 millimeters. And you open the soft tissue, partial thickness, okay? So the tissue is still bonded to the tooth. Never bypass the 9 millimeters of your blade. The flatter the palate, the closer the nerve. You can really look it on the crest. We make an incision. Usually I change it. I always cut to the bone on the buccal. Then I elevate. I see the amount of tissue I need. And then I go forward, maybe sometimes up to the first molar, based on the amount of soft tissue I need. So then we rest on top of the tooth and we detach it from the bone and you cut it at the base. And this is the amount of soft tissue. This is Angus beef. Okay. The palate is McDonald's. Okay. So, and then we suture in one line. The needle should go once, and we don't go one and then the other one. What we want is to have a precision on the adaptation of your flaps. So we go once. All my needles are long needles, 17 to 19 millimeter long needles. And just to control, I level my flap and then I go across. Okay? And you finish. Okay, so this is the greater palatine artery, the distances, and there is a fantastic relationship of your greater palatal artery related to the anatomy of your void, of your maxillary anatomy, and there are great studies showing you the distances. But what I would like to show you is the study we did. Does the harvesting technique matter? It's something that I can I would like to share with you. We have done cases, and this is, for example, done by a student. Okay. And what we did was we removed the soft tissue from the palate. And as you all know, what we want is to get rid of the epithelium. You can see here, we did a histology. And what we did on the study was we took a dentist from Grad Perio, and they took the piece of tissue and they de-epithelize outside the mouth, and the other group de-epithelize inside the mouth. And then we look at the microscope and check if the guys that did it better taking the tissue outside or better taking the tissue inside. And we saw when we look at the microscope to check which one was better. Okay? So why is it important to de-epithelize our connective tissue graft? Well, because if you don't de-epithelize correctly, you will have micro pouches. The tissue will never adhere. You will have like voids within the tissue. And those voids will come up to the surface. Okay? And then you will have a problem. This is something that was done, only 2 papers that I know of. I was involved with this paper with histological evaluation, which is much better done than the previous one. So you can see that even when you take the soft tissue from the tuberosity, there is one place that many people forget, which is the sulcus. The sulcus of the second molar, which need to be removed. Not only the epithelium on the crest, but also the epithelium from the sulcus. And these are little details that make the difference. Okay? So, if you don't take it, there is a lot of articles showing that you can have problems. And more we are doing connective tissue grafts, and this is something that you should be aware of, that dependent upon the technique and how you do it, you can create problems. So let me show you one case of mine. Let me show you one problem I got. And let me show you what happened. So this is a patient come to me like many years ago. Has a fistula here, has diastema. The fistula is coming from number 11. This is number 11 versus number 21. What would you do? I always start from the most difficult one, which is 21 or 11. Who says 11? Raise your hand. Come on, it's just a game. How many of you will place an implant on number 21? Which one would you start with? Okay, so let me show you. First I did some composites, because the guy is the same day composite, like 3-hour composite. Just one dentin and one enamel, has the same clothing, okay? He's happy. I'm not, it was a difficult case. I polished everything. And the first thing I'm gonna do is I'm going to extract number 21, which is the most difficult because it goes all the way up to the nose. I place a membrane in the base of the nose and I fill it. This is the day 0. I fill it with xenograph material. And then I did an incision on the apex to get into the root, graft it with the membrane and packs. Use EDTA to seal as much as possible the root. I'm going to do 1 implant at a time. I'm going to wait 8 months before I go ahead and place my implant. You can see the resorption that happened. And once I have done my implant, please notice that I have bone resorption vertically of 2 millimeters. And this is something that I would like to address, that I always, depth is crucial on grafted side. I never place the implant level to the bone. I always deepen my implant at least 2 millimeters, because I know that 2 millimeters, that bone will resolve, and I will still want my implant to be buried into the bone. This is something that we learn the hard way. And then the GS place an immediate implant placement in here. I did first the delayed implant, and then once I have done the delayed, I see I need a circle connective tissue graft in here. I did a circle connective tissue graft and then place my implant. This is how it looks like 6 months down the road. You can see I still have bone loss. I finished my case. This is where I started. This is where I finished. From bone loss on the central incisor. So the patient asked me, hey, I love it. It's 2011. This is 2011. This is 2018. This is 2021. What do you see? The diastema. So I always, and what do you see? He was asking me, hey, I have a little amount of space from endodontics here. So what I did is I de-epithelialized with the burr, and then all the micro fistulas came out from the tissue underneath. So I opened the problems. Why is that? Because my tissue was not well de-epithelialized. And this is difficult to solve. Actually, you never solve it. And I would like to share my problems too. You can see I use many times laser. I even cut the surface, making it rough. So in this case, this is a video. Please, I took my crowns off. These are the abutments I used at that time. And what I'm going to do is I'm trying to get rid of these micro pouches. Okay. Please pay attention what I mean by that. You can see this is the view on the number 21. And I squeeze with my finger the local soft tissue. And please notice everything that comes from the soft tissue. This is micro pouches. I never de-epithelialized, so you will have bacteria in between because of the poor removal of your soft tissue. Okay. So We use laser to de-epithelialize, but it's really difficult. You can improve it, no question about it. And what I did is I de-epithelize, I did a peeling. You know that the epithelium grows really fast. I go into all the little fistulas and try to de-epithelialize, but I don't have a microscope in my eyes. So basically I'm working blind, okay? And I'm trying to cut the soft tissue and then trying to rebond, reattach this fistula. You can see how many. And this is because the soft tissue was not de-epithelialized correctly. So you can see the problem this de-epithelialization can cause. So we sutured it, we go all over, so we increase the speed of new soft tissue, which helps on the overall turnover of the soft tissue. And you see, we are going to suture now. All those holes we try to use a short version of the video, but we go from the inside, outside in, inside out, in order to try to blend all those micro pouches and be able with suturing and getting rid of this superficial epithelium to really be able to blend the layers, okay? Which is almost impossible to create. And this is thank you. And this is all the suturing, okay? This is how it looks like, and then we plate the final crowns. We did 2 splitting final crowns. Today, I already extract this implant. I regraft everything, and now I'm waiting how much bone is in there to decide what I'm going to do. If you see, dentistry is not an easy game. So this is Goso, who did the research, and he demonstrates that you have 83% of chances of removing all the epithelium if you do it outside. But if you do it inside, you have 86. So you have more chances to remove the epithelium inside the mouth than outside the mouth. Why is that? Well, first of all, is for me, I like to do it inside because I see the color change, and I have more control about how much tissue I'm taking out. How much should I take it out? Can vary from 200 microns to 600 microns. So if you take with only 1 millimeter of epithelium, it's more than enough. What is important to know that is when you have a really thin phenotypes, the problem is sometimes by the time that you take the epithelium off, you are just left with nothing. So if you do it in the mouth, you will always come up with bigger amount of soft tissue. I want to show you something. I want to ask you, how do you do it? Do you cut first, or do you de-epithelialize first? And the question is really important. Okay? Every time you cut first,
mỗi khi mà mình
you have a problem.
sẽ có vấn đề như vậy.
Why? Let me go back. Let me show it again. If you cut first,
Khi mình cắt trước
like he did here,
như là ở đây,
and you go with the burr,
sau đó mình mới khử
the soft tissue, when you place the burr, where you have cut it, the soft tissue will do this.
khử
So you will always end up
mô màng nó sẽ
with pieces of epithelium on the line angles, on the corners, all over the place. So this tissue is full of epithelium.
cái vùng gốc này còn đầy vô hết.
So you can use a diamond burr, okay, but you can see this tissue is full of epithelium.
Thế đó, khi mình
What is that epithelium? Just on the line angles, on the corners. That's why we never cut before. We de-epithelialize first, and then we cut afterwards. Okay? This is line angles.
đây là
It's
cái
full of epithelium.
trên mô họng,
Okay?
nó còn sót trên mô họng.
So line angles are crucial.
Nên cái đường viền nó rất là quan trọng.
So I would like to show you
Thì
how do you protect the palate.
làm sao mình có thể xử lý cho cái vùng
How do
chóp.
you do it? Do you suture first?
Mọi người sẽ không
Yes or no?
đúng không?
Well, you have to suture first.
Tại sao
Why?
mình phải khâu trực?
Because if you are pretending to place your collagen inside,
Collagen này ở trong
the blood is gonna pull
máu, nó sẽ tràn ra
your collagen. So you first
động của cái collagen.
suture,
Cho nên là mọi người hãy
and once you have suture, you slide
rồi sau đó mình luồn cái miếng collagen này bên dưới
your collagen,
không,
which is much easier and
nó
faster.
sẽ dễ hơn và nhanh hơn.
Do you use something to cover?
Mọi người có dùng cái gì để mà che
Can
lại
you use
cái
periacryl? I use
Không có dùng periacryl thì tôi dùng
cyanoacrylate from the supermarket. Okay? And I will show you how we do it.
sẽ
So we first suture, then we place our collagen, then we place our cyanoacrylate, and then we polish our cyanoacrylate.
máu vào
I cannot show this on the
sau mình bóc
periodontal meeting of the year because all the periodontists they get crazy, but this is the reality, it works.
thì thực ra đây là một
They will tell you, no, because this cyanoacrylate is poisonous. So far, nobody has died yet from
thực tế
that.
là các bạn tôi đang làm thế này.
So, I have a few questions to ask you,
Có một vài câu hỏi đặt ra.
and I will show you a case where I failed,
Tôi sẽ cho mọi người xem một cái ca mà tôi thất bại.
I took soft tissue, okay? So, I take the soft tissue, I have an idea how big the soft tissue will be. So first, I cut with my burr without water, because if not, the patient is choking. So, no water, and you take your epithelium off, and then
Rồi sau
you
đó
cut your epithelium. In this way,
miếng ghép này,
your line angles will be free of
mọi người thấy nếu như mình khử trước á,
particles of epithelium.
viền của
Then you do,
không bị mô này.
the more I do free gingival graft on the buccal, the more I suture and go away from the free gingival margin. You need to remember that the thickest tissue is on the alveolar process, the closer to the tooth.
Mọi người nhớ là cái phần mô mà
So I place I glide, I elevate my suture and glide my collagen.
ngay sau khi
And then what I do is you can de-epithelialize with laser. Those are
tôi cầm móng tay mình laser.
the settings. 2.5 watts
Mọi người thấy ở trên
with 75 bulbs, 20% air and 40% water. Sorry. So you de-epithelialize,
ở đây mình khử
You suture, you put your collagen, and then you put your cyanoacrylate.
mình bôi cái
You dry it.
cyanoacrylic acid vào.
Usually, how you set the cyanoacrylate is with spray of water. You take spray of water from the outside
Mình để mà kích thích
and
cho
you
cái
set it out.
cyanoacrylic acid nó đông
You
lên,
dry it
có thể
and you place
xịt
another
lên
layer
ở ngoài
and
này.
another layer. Usually, I place 3 layers,
Đặt thêm một lớp nữa rồi mình phải xịt
and I don't remove it
một lớp.
after 2 weeks.
Tôi sẽ tháo cái lớp keo này ra sau 2 tuần.
Let me show you a video. Okay? So it will be clear in your mind. This is the way that I'm going to do a recession on an implant, on a central incisor, on a lateral incisor, and on a canine.
Kích thước của
Okay? So this is the way that I calculate how much I will need. The quantity of soft tissue goes from line angles to line angles. Okay? And then
rồi sau đó
we'll show you all the different steps. Okay?
qua cái video này
So I measure, I need at least 3 millimeters of, this is the,
thì mình biết là bây giờ mình phải lấy một cái
how
kết
much I will
đầu
need.
của nó khoảng
So I go
mình
and de-epithelialize the soft tissue, because only one ridge in there. I want to keep the tuberosity in the back. Then I cut inside what I have de-epithelialized and remove the whitish part. So I want to keep as much
ở đây tôi sẽ có
yellow that I see.
cắt lọc lấy ra cái phần màu trắng
What I want to remove is the whitish, the lamina propria. So this looks like this. Now the first thing I'm going to do is I'm going to
rồi bước tiếp theo
suture.
mình sẽ
So I go distal mesial, distal mesial.
chứ không
I'm going to do some
xa
recessions.
đến phía gần
So I'm going to go distal mesial, distal mesial. And once I have suture, then I will glide.
luôn
I have a cube.
bông cầm máu vào
I squeeze it.
rồi mình đè xuống
I have a cube. And what I do is I blend it in two. Okay. I squeeze it and then I glide it below my suture. Okay. Once everything is adapted, I dry it.
mình đã luôn
And with the spatula, a Miller spatula, I go below the contact points and I throw spray of water. I dry it, spray of water, I dry it, spray of water. And what I want is to control that the liquid doesn't go to the throat, okay? So once everything is dried, I go with the burr and polish it so it's not as rough for the patient and it's comfortable. Okay? So this is the way that we have been using for the last 20 years. It works beautifully. The patient tells you, I don't feel anything, I can eat from day first. It's not a big problem. You can see that my hand doesn't, I can take as much as possible. I don't use any stent anymore. I use cyanoacrylate and it works beautifully. The second question I want to ask you is if I need another connective tissue graft and you have taken it from one side, where do you taken it again? From the same side or from the contrary? You take it from the same side. Why? Because the tissue will be thicker and denser, it will be more fibrous, and you will have more lamina propria the second time than the first time. So how much do I wait? Minimum 4-5 months. You can go back to the same side, exactly to the same side. Okay? Let me show you this case. Easy one. Lateral incisor, central incisor, class 2, huge class 2. So we're gonna place extraction on number 12. Place 2 implants and cantilever of the lateral incisor. So first we're going to do a socket preservation here, and we're going to do connective tissue graft on the central incisor to decrease the resorption, as I showed you before, because there is no bone. And then we'll do 3 unit bridge. This is the situation. You can see huge class 2. So the first thing, you see no bone, the buccal. Let's see no bone on the buccal. Little amount of bone. So here I show to the patient that I would love to use the provisional. I'm going to close the diastema, make a provisional from both central incisor and to the lateral. And I told her, well, I would love to have a better soft tissue leveling, so I'm going to do the day of the extraction of the tooth and bridge preservation, socket preservation with do connective tissue grafts on the teeth. Okay? But the connective tissue exploded. This is necrosis. This is because my flap was not, I pretend to place too much soft tissue in a small space. So now we have a problem. Big problem. Because now we have to wait. I'm going to reinforce. I'm going to take my laser or my electrosurgery. Please never pull. It stings like crazy. It looks like a dead cat on the mouth. So what we will do is, you cannot cut with a blade because it goes all over the place. So the best is to have an electrosurgery to cut all the excess that is coming out from the pink area. You remove the provisional, you take all the yellow part which is necrosed, and then you resuture. You improve the antibiotics, we give metronidazole, and we see the patient every 4 days. Now the problem is, how much do I wait for the next connective tissue graft? At least 9 months. Why 9 months? Because this tissue is growing by secondary intention, and the quality of this tissue is really poor. So if you don't wait enough, you might have the same problem. So this is the day of that I saw the problem, 2 weeks after. Usually I see all my surgeries 1 week after. Why is that? Because between the 4th and the 8th days is where you have the plasmatic healing. And I want to see that this is closed, that is not open. So in between 1 week you are able to see if you have a problem or not. Okay? So usually if I have a problem, I take the provisional off. I take with electrosurgery or with the laser all the yellowish part. I resuture, I give antibiotics, I show the patient to use gels to maintain it as disinfected as possible, and I see the patient every 4 or 5 days. I resuture if necessary, until I get to a situation where this is 3 months after. Okay. It's not bad, but I have lost a lot of verticality interproximally, volume-wise. And then I tell the patient now to have to wait 9 months. Yes, 9 months before I go back. So this is day 0 of the problem. This is 3 months. This is, I add a little bit of acrylic, and this is the Pontic 9 months after. Okay? And then I go back to the same place that I took the soft tissue from. So I took the soft tissue from this area when I did the rich lab, which is just here. So I'm going to take it from the same side. Okay? Usually they say within 3 months you can go back. Usually I wait. In 9 months you have really good connective tissue back. So this is my soft tissue, and I cut it in half and did the sushimi steak. The most important is that it's sutured with resorbable suture, and it's just perfectly fitting the papilla. Okay? And then what I want is to elevate the flap. There is no, everything is with incision, circular incision, vertical incision, everything has been tunneled, and the connective tissue goes through the tunnel into place. Okay? I want to just suture it on the crest. Okay? Once it's sutured on the crest, as you can see here, sorry. Sorry. When it's sutured on the crest, what I do is I reline my provisional. I don't want my provisional to be pushing the soft tissue. I want to maintain it just right there. So coming back to the process, day 0, I always see my patient between the 6th and the 8th day to see if I have any problem. If I like it, then the patient comes 15 days later from the surgery, take the stitches out, I check it again 1 month later if everything looks great. And then at 3 months, I either take the final impression or I need the second round of connective tissue to improve the volume. And again, I see every 6 to 8 days, 15 days, stitching out. Okay. So 15 days later, I cut the stitches off, and I take the shield that is protecting the wound. The wound looks like something like that. This is 15 days, but the patient is now not in pain anymore. She can chew on that area. It will be a little bit of awkward the first day, but after it's great situation. So here we place the 3.5 implants, as I mentioned this morning, and you can see all the bone. Here we have the proximal bone, and this is about 3 months later how the bone is just almost attached to the zeal and multi-unit abutments. You can see the extrusion of the lateral incisor. So we remodel the soft tissue and make a veneer and splint it to the canine to finalize the case. So this is the trying of the bake and a prep of the veneers that we cut incisally, and then Yoshi sees the value and finish the case. You can see the papilla is in the right place, everything is level. And then we finish the case. This is cantilever of the two implants. Where we started, day 0 of the healing. This is 3 months. This is the final work. So we have optic, implant, one piece, and then a veneer on the upper incisor. You can see the view from the top, where we started and where we finished. You can see the bone stability, the soft tissue problems we have. So you can see the stability of the veneer with the wire intra-coronal. You can see here the wire has been bended and you feel the contour of the tooth. Okay, this is where we started. In this case, you can see the papilla height, volume on a huge class 2. Okay, so let me show you this case. It took me 3 rounds of connective tissue. He's a cardiac surgeon, heart surgeon, really famous in Paris. And his brother is a periodontist in Washington, D.C. And he said, if somebody can do this, you have to go and see Iñaki Gamborena. So he's coming from Paris to have this surgery done. This is after 3 rounds of connective tissue graft. So you can see everything you see in here is mucosa. So the soft tissue didn't keratinize the flap on top. Okay, so I have a problem. He's happy. I close all the spaces only with composite. This composite here, composite here, composite here, composite here, composite here, composite here. No veneers, no nothing. Okay. And why the soft tissue of the overlying epithelium keratinizes is due to the elastin. It is really well described in this article. So this is my first connective tissue graft. This is what I was able to gain. This is my second connective tissue graft. This is my gain. And this is my third connective tissue graft. So this is what it looks like. He had aggressive periodontitis. This is once I finish all the composites, how the tissue look like. This is 1 year after I finish. And then I say, please allow me to do the free gingival graft. So I could have a better sealing of your soft tissue. So this is what it looks like with the iPhone video. And then he came back a year after, and I did the strip technique from hand, and I will show you more cases about this. And one strip from the buccal, and one strip on the bottom, and then the tissue will take the information, and this is pretty much a year after where we started or where we finished. Right? Not easy, but possible. Okay? I use tuberosity also on big defects. You can see here another one. Looks like a bullet. Hiding line. We did orthodontics in 2008. So I do a connective tissue during the orthodontics. I kept one of the teeth I place the implant,
Đặt Implant.
and every time you want to improve the papillas, you have always to graft on the adjacent teeth. Okay?
Tái tạo
So we need always an extension.
cái răng tiếp theo luôn phải có một phần mở rộng bằng răng tiếp theo.
You will see the implant back, and then now we use a slim healing abutment. It's a temporary slim healing abutment. So it's basically, usually today I get rid of all this fatty tissue and make an incision. So the tissue is being sutured to the palatal.
Rồi sau đó sẽ không
And then we make some extensions that will go over the adjacent teeth
qua hai cái
in order to improve the papilla and to diminish the recession of the adjacent teeth. You can see those are really old videos
nó sẽ khác.
to show how we manage not only the defects on the implant and the interproximal, but how we manage the flap on the adjacent teeth.
Xử lý cái vàng
So we cover with extra soft tissue the adjacent teeth in order to overcome the vertical defect. And then the flap will be no vertical releasing incisions and will be closed on top of everything. So you can see we're coming from the buccal aspect, getting into the flap, going back, leveling the soft tissue where it's necessary, and then covering above and below the prosthetic part of your healing abutment.
vị trí của mình là cái từ đầu nữa, mình sẽ kéo cái cánh nó ra ở hai bên.
We do the same for the central incisor. And then you will cover everything
Sau đó mình sẽ che tất cả vùng ghép và cái vàng của mình.
and suture it. Okay? So you can see the bigger amount of soft tissues on the crest,
Thấy là ghép của nó mà rộng
and nobody can tell where is the incision. Okay?
nhìn vào thì rất là khó có thể
So this is
đặt nó ở đâu.
2 weeks after.
Cứ đợi 2 tuần.
Taking the stitches out. You can see how much volume we were able to reach
Phần thể tích của mình
and
phải sinh
the
lượng
case you
nó
have seen. Okay.
rất là lớn.
So I will jump into these cases because they are pretty easy
Sẽ nhảy nhanh
and
qua
show
cái
you
này
more
khá là đơn giản hơn.
interdisciplinary situations. The tooth where we grafted easy case, final result, having the same volume in both sides.
Nó khá hài hòa giữa
So let me show you this case. It's a difficult case. It's a multi-unit, multidisciplinary approach,
ca mà tôi phải điều chỉnh
bringing the central incisor and
điều chỉnh cái giữa có hai cái răng giữa
the lateral incisor is a canine
bên
and the first bicuspid is a canine.
sẽ
So every time you bring teeth forward, you need to reduce the diameter of the teeth. And this is something that the periodontist should be doing. Okay? And this long case, difficult case, and wanted to bring midline. So you can see that we did the crown of the canine because it was huge, the reduction. We placed really small healing 15 abutments, and we'll go into that shortly. The incision is always buccal in order to improve the height and the thickness, okay? And use the implant to bring the premolar forward. This is how much the orthodontist was able to create. This is the implant, this is the canine, and this is the first bicuspid. So what I want is make a mock-up and see how much can I do. This the situation here, and here is how much I want to bring the soft tissue down. On the root, I want to decrease the diameter of the canine into a lateral incisor. So we did a root canal in this case. That's the root plasty that we did in order to transform the canine into a lateral incisor before doing the connective tissue graft. Okay? And then we did the connective tissue graft, and we took full tuberosity into the lateral incisor and to the premolar, which we want to have look like a canine. Okay? So you can see a lot of work that is done prosthetically and surgically to optically come up with a canine that looks like a lateral incisor and a premolar that looks like a canine with these contours. So this is on the top, the aesthetic mock-up, in the bottom, what we were able to create surgically with connective tissue graft and reduction of the roots. Okay? So you can see the papillas now are very much leveled. It's a matter of changing the crown and finish the case. Okay? So you can see we did a veneer on the canine, the crown, on the lateral incisor. We modify a little bit the contours, and this is the finished case. Okay? What about keratinized mucosa? Usually is a bridge, 5-unit bridge with 2 pontics. And these are typical cases where you use connective tissue graft, you do a bridge, and you are full of mucosa. So the patient even tells you when this is moving. So usually I do 3 gingival grafts from the same color. I don't take 3 gingival grafts from the palate, especially if the patient shows me. And this is the pontic. Where we started and where we finished. The bridge goes from lateral incisor to the canine. I'd like to show you another one. We place implants. This is a problem because I was stupid enough to keep the tooth between implants. But my idea, I wanted to keep this tooth because it's crucial to create my bone grafting and leveling the bone in this area. So if I would extract this tooth, I would have lost height and horizontality. Maybe I should have done a bridge instead of placing an implant. Because if I place an implant here, then this tooth is going to move and it's a problem. Okay? So maybe I should have done a bridge. I did orthodontics, but on cases like this one where you don't have, it's all mucosa, then you will have problems. Usually if the patient doesn't show, I take the 3 gingival graft from the palate. Okay? This is the result. I don't care about the color because the patient won't show it. But if the patient shows the interface between the crown and the soft tissue, then I don't take the 3 gingival graft from the palate, I take it from the buccal aspect of the posterior teeth, and I will show you some cases. So this is the final case, and as I told you before, this doesn't come out of the blue. This is the trying of the bisbake. My technician is here. This is COVID times, and I'm just telling him he needs to see what is in the mouth. And I'm telling him, hey, listen, you closed much my space. I want you to open it so the papilla will come down. I have grafted. Don't worry. Leave it open. Don't close it. Bring the tooth out more. I'm asking and telling him all the needs I see. I want you to create more pressure on the central incisor to center it. The value is okay. I love, you need to open the incisal embrasure. You open too much the canine here. Try to make it copy on the other side. Try to level the papillas. And then the problem is that we have a natural tooth between implants. And say, Yoshi, we have a problem, you need to help me here. And what he does, he creates a hole. I will show you different situations, different results. And here what he does, he creates a hole. So we'll cement first the lateral incisor to have a perfect fit. And then we will screw retain the bridges, and we will use a wire which will be bonded to the adjacent teeth. So in this way, these tooth will move. The contact points will be the same, and these tooth will never have the chance to move. So this is what it looks clinically, how we finish the case. Before we started, I did the orthodontics myself. I did some internal bleaching here. And finish the case. Okay. Let me show you the result. You can see the show. Let me show you this one. This is maybe one of the most complex cases. This is Korean. Okay, he went to Barcelona. This guy is coming from south of Spain, from Valencia. Actually Alicante, and they did a curry in Barcelona, and actually he has bone, but he doesn't have soft tissue, he doesn't have space, he has many problems. It took me 7 years to see what I'm going to do. Okay? So the first thing is that I have to center the midline because the midline is off by 1.5 tooth. So I want to center the midline in order to allocate the canine and the first bicuspid, which are missing on this area. So this is the second bicuspid, first molar, lateral incisor. First thing I'm going to do is I'm going to do a free gingival graft. Okay? Why? Because I'm going to move those teeth. And these teeth don't have any protection at all. So I will be losing more if I don't graft those teeth before the orthodontics. Okay? And what I pretend is to center the midline, like half a tooth or more, in order for me to, this is the situation, and I'm going to ask my orthodontist, in this case, one of the best orthodontists in Spain. Take your time. I have no rush at all. Take your time and move the first bicuspid into the second bicuspid into the first bicuspid. So what I want you to do is this. Okay? Once you have created the space distal, go slowly because the problem is that I don't have too much bone on the mesial aspect. And moving these tooth in such a hard, dense bone, we will lose some resorption on the tooth. So take your time. I have no rush. Bring the tooth forward. Once the space is open, you send me a WhatsApp. And then if you have the same space, then I will place an implant here to just finalize the movement. Use this implant as an anchorage to bring the teeth forward and place another implant in the front of the first bicuspid. So this is what we do. He brings everything forward. I have the space to place an implant. Sinus is there. I have a short implant. You can see the little amount of bone after the second surgery. And now the problem is I did 3 gingival grafts, but now I have 1 implant in the front, 1 implant in the back, and a tooth in the middle. How do you solve it? Well, here what we did is a 3-unit bridge, and we place and make sure that this tooth is not touching the copping, just on the edges. I'll show more cases like that tomorrow. So here you have single crown with a trough on the zirconia. So we will bond this trough. Here we didn't have space to make a hole on the zirconia. So if you see the tooth here, there was no space to make a hole. So what we did, instead of making a round, we make it divergent. Do a mechanical retention with my composite and have the wire inside. Okay. So this is one possibility. And then I have the cupping and I do the bridge on top of my cupping. So the cupping really, what it does, it protects from decay. You can see the bone is coming back, and the root is holding the volume of tissue and bone. It is a single crown on the posterior tooth. Can you take the note? So this is the final case. You can see here we have the crown on the lateral incisor. We have nice keratinized tissue. And we have the second bicuspid is now the first bicuspid. And then we have the implant in the back and the crown. This is where we started, we did bleaching. So let me show you more difficult cases and how I treat them. Okay? This is my neighbor at the office. So it's a problem, always treating your neighbor, always a problem. Okay? And we're gonna do big bone graft. And she's wearing a removable. She's younger, she's on late 40s, and she has been wearing a removable partial denture all her life. So she's missing from K9 all the way up to second bicuspid. So you can see she has lost horizontal and vertical volume. She shows everything. So this is the idea. So I asked her, listen, we can place 4 implants here, a little bit of pink ceramics, and we are finished with it. No, I want no pink. I have seen some patients, I don't like it. I say, well, the other option is it's quite difficult. because we'll have to overcome all the loss with either bone and soft tissue, so it will take longer. I don't care, I want the best. Okay? So it's gonna be a long journey, I guarantee you. So this is what we did on her. We placed 5 implants on the top. I did a Curie technique, but I didn't use patients on bone. These laminas here are from pigs. These lamina from a pig, lamina from a pig, lamina from a pig, pig. Okay? These laminas are 1 millimeter thick, and usually I have to wet it at least half an hour before I place it back. And then inside, what I use is 50% autogenous bone, 50% xenograft material. So let me show you the case. This is the video. I will go fast. Sorry. So we do always buccal incision. I want to have an idea where the implants are going to go, and then I will make an incision buccal to where the implants are going to be. Why is that? Because it allows me to close and create verticality on the soft tissue. So I make it, the incision is really important to really be able to close it afterwards, because what I want is to create vertical and horizontal. So I open it, I de-epithelialize. I love this instrument, which is from MGK, that is triangle, and is the VLU001. So I'm able to pull easy my flap and cover it. I have to go over my palatal. The stent has a hole on the palatal aspect, so I put my flap on that hole, so it's not. I place my stent and stabilize it and suture my palatal to the central post, which is holding the stent, and then I do my training. Place my implants. This is the N1, the tiger, and you place my implants, and then have an idea where the height based on the stent of the provisional restoration, how much bone and how deep those implants are going to be, and how much I'm going to upright my provisional. So not big deal. I do this lamina, cortical lamina. I adapted. I used piezo, and I fix those lamina that can be bent. Okay. And I position. This is carpentry. Then on the palatal aspect, I place where I want it. So it's much less morbidity for the patient, because this is coming from xenogenic material. Taking this amount of piece from the patient is, you can wedge the parts, you have all your time. Just scratch some bone from the rest of the mouth, okay, and then you fill it with 50% or 60% autogenous, 40% xenograft. You fill the spaces. You can use a membrane to be advisable. Here we use only LPRF. I should have used a membrane, a collagen membrane, and then an LPRF, and we close the wound. Okay. This is where we started. Sorry. This is 8 months later. How it looks. Be careful if you ever use this xenogenic cortical plate. Be aware that you need to use autogenous bond so it doesn't become a sequestrum. Okay, and you need to integrate as much as possible with autogenous bond with patient's own blood into the patient's body. Okay, and stability of the auspices, as you all know, is mandatory. It's crucial. So have a great blend. I should have used some sort of higher healing abutment in order to bring the bone more crystalline, and this is what we do today. And in this case, we place some multi-unit, ZIL multi-unit abutments with 70 degrees and 2.5 millimeter. The problem of grafting crustally around such a big healing abutment is difficult. We do it totally different now, and I will show you some cases maybe tomorrow or later on if I have time. But trying to really be able to graft on the crust is pretty difficult with such a big healing abutment. It's possible, but it's difficult. The idea here is to have the narrower healing abutment, and there are some ideas I will be able to share with you to really able to create that. So today with the slim concept that we came out with, we use guiding pins, which are just for guiding the position of the implants. We use these as a healing abutment rather than this. So here I can graft crystally with a rod that is 2 millimeters. And I will show you some examples later on where you can graft and create and perform really high aesthetic results. Okay? I'm a periodontist, and the way that I was taught is that after this I need to increase the keratinized mucosa. And should I do it before or after the provisionals? And for me, the best is to put the provisional first, because now as a surgeon, I have an idea how much keratinized mucosa I need to graft. You can see the mucosa line, the mucogingival line. You can see that we have a problem, especially aesthetically. The patient can tell you, yeah, I like it, but what about this moving thing here? Can you get rid of it? Yes, we'll have to do a surgery. But the amount of surgery we have to do is huge because I don't have enough tissue to graft from. Okay? So the problem is going to be the color, because the patient is showing everything. So how to increase the keratinized mucosa? You have 3 ways. You can do a free gingival graft, but here the patient is showing it. I'm taking it from the palate, or rotate the palate. I'll have the rugae on the buccal area, which is rather ugly. I can have the strip technique, autograph, or the apically reposition, but I cannot apically reposition because I don't have any keratinized mucosa to start with. So If we take the provisional off, you can see that there is little or non-existent keratinized tissue just here, a little bit here, this all because are due to the buccal incision, of course, and it's really for the manipulation of the plant. So what I did is the hand and paquet strip technique, which is sutured. The buccal strip is taken from the buccal aspect and is sutured the most incisal part. Then you create a bed. The most important is to suture the lip where you think the vestibule will go. And then with the palatal strip, you're better off make strips that are wider, at least for me today is 3 millimeters in thickness. And I want to show you what happened. So I suture, and those are the strips from the palate. And you can see here the strips from the buccal aspect, both sides, that were sutured. This technique was popularized by Van Urban because he came up with an idea that you should place like a xenogenic collagen matrix in between the bottom and the top graft, but for me I think it doesn't make any sense at all. You get the information, the genetic information from top and bottom, and you get the soft tissue. So we have now, I use derma from osteogenos. It's easy to suture, much better than the one from BIOS. But I want to show you what happened. Okay? The most important of this technique, having the provisional restoration as a surgeon, it gives you a better idea how much gingiva you need. I was planning to have 6 millimeters. And you're gonna see what happened. This is just 2 weeks compared to 3 months, and the tissue grew back. Why is that? Well, I was not careful enough to suture my lip into the position. So the most important is to suture the lip exactly where you want it, because if not, you will go back to the same position. So now I have a problem because the patient went through one surgery and I was not able to reach what I wanted. So I told her, listen, when I place the final zirconia bridge, I love these bridges from Nobel, and what we did was a full contour bridge. You can compensate up to 25 degrees. We put the tissue, and these are the omni-grid screws, and this is my reality. I still have more keratinized mucosa than before, but it's not what I was planning. So Yoshi finalizes bone-wise, everything looks beautiful. We are really happy with the connection. This is the reality of what I have in the mouth, so I'm planning to place the final zirconia abutment, so the soft tissue will heal better against the zirconia than with my provisional acrylic bridge. So you can see the situation. It's very nice, but it's not optimal. So I don't do dentistry For my patients, I do dentistry for myself. Okay? So I place and I push the tissue with the final zirconia abutment. And then I decided to, this is the day 0, how it looks like. Of course, this tissue will come down. This is how it looks like with the provisional. This is how the tissue creeps back. But what I'm going to do is I'm going to reposition apically my soft tissue. So what I did is I cut part of my mucogingival line. Here is the tricky area. And now this time I'm going to suture really well against the periosteum of the vocal to really level the soft tissue. And this time I will bevel the soft tissue so I don't have a step. We use laser, as you will know. Epithelium grows 1 millimeter every 2 days. And it's amazing how the tissue grows by itself. I bevel it. This is excuse me, the video of the de-epithelialization and the position of the flap. You can see part of the flap, and the repositioning has the same color of the soft tissue here. So everything has the same epithelium, and then tissue will grow in between. It's just 2 weeks after. You can see here how it looks, the different stages, and the difficulties. The difficulties we have been encountering just to get to 4-5 millimeters of free gingival of keratinized mucosa. So you can see 4.5 normal scallop. We have implant, ontic, implant, implant, ontic, implant, implant. And you can see how much tissue is pressured. As soon as you take everything out, how the tissue rebounds, where we started, how we finish. We did a veneer on this tooth and in this molar and a crown. Sideways, we did bleaching in the bottom. We did some bridges on the posterior, lower posterior. We opened the bite, and the final work. Coming back, just one circle, one remark. Usually, if I have one molar and I have loss of vocal, bone volume, and height, I prefer to do a bridge than to implant. Because if not, it's difficult to catch up the same volume loss even with bone graft and soft tissue graft. I prefer to do a 3-unit bridge. Patient is more comfortable. We make narrower ontics. It works really nice. This sideways is the iPhone videos from different stages. This is 1 year and a half. And this is the smile with the removable partial denture and with the fixed bridge. With the Nacera crown with N1s and the Z abutment, where we finish it up. Okay? Good. So we are done for this afternoon. Tomorrow, more and more difficult. I know that you have a lot of cleft palate patients, and I will show you some cases that you have never seen before and how difficult dentistry can be. Okay? So if you have any question, maybe we can keep it for tomorrow. Please write it down. I'm rather tired. And tomorrow, more and more intense. And we look at more difficult cases. Thank you very much.
Thank you very much, Professor Gamborena, for your very interesting presentation. We look forward to tomorrow. Kính thưa các anh chị đồng nghiệp, thì chúng ta đã qua một ngày làm việc rất là tích cực, và tôi nghĩ rằng kết quả chúng ta được chắc chắn rất là cái chúng ta kỳ vọng. Chúng ta đã nghe được những cái trình bày của thầy, báo cáo của thầy, những cái đề xuất của thầy, có những quan điểm